My case is titled Patient with ACS and Proximal Lesion, how the intravascular imaging changed the treatment strategy. This is the background. 62-year-old gentleman present with central chest pain since 2 days. He has history of hypertension and diabetes. Electrocardiogram at the time of presentation showed evolved anterior acetylation MI. The echocardiogram showed an ejection fraction of 45%. So he was initially stabilized with antiplatelets, heparin, and other supportive care, and then taken up for angiogram. This is the angiographic images, which showed that there are two tandem lesions in the proximal LAD, which appeared to be around 75% and 90% each. Circumflex was a dominant system. There was diffuse lesion in the distal circumflex. But in cranial views, there was some eccentric lesion in the mid-left main, which appeared to be not very significant. While right coronary artery was abnormally originated as a codominant system, diffusely diseased system, distal PDA was diffusely diseased small caliber vessel. So we thought that we will perform PCI to the LAD lesion, which was thought to be the culprit. So we started off with an intravascular imaging, started off from distal LAD. There was diffuse lesion from the distal LAD. We could identify a relatively plaque-free zone near the origin of that second septal, where still the plaque burden was around 35%. And the distal reference was about 5.3 millimeters squared, and reference vessel diameter was 3.9. It was predominantly a soft plaque with some areas of superficial calcium. And the tightest point, the lesion plaque burden was 85%. So at the LAD ostium, it was preserved lumen, but the plaque burden was 47%. The reference vessel diameter at that site was 4.3 millimeters. There was plaque from 10 to 5 o'clock position. And when we came to the distal left main, the distal left main had a high attenuation plaque, and mid shaft had a compromised lumen. It was 4.8 millimeters squared. The plaque burden was 72%. And the ostium of the left main had a concentric plaque with possible calcified protrusion at 12 o'clock position. So even though angiographically it appeared to be a very straightforward lesion, but the intravascular imaging showed that the lesion was extending all the way from mid to distal LAD to ostium of the left main. We performed a pullback from the circumflex. The ostium had a plaque burden of 23% and a lumen was 7.3 millimeters squared. So the strategy was a provisional side branch stenting strategy to place a 3.5 millimeter stent from ostium of the left main into the middle LAD. We didn't have a reference segment in the left main to estimate the reference vessel diameter, but we went by the fractal law. We thought that we'll perform a pot with 4.5 balloon, then recross, perform a kissing balloon, and then repot, and aim for an MSA of more than 10 millimeters squared in left main. So a 7 JL 3.5 guide, pre-dilated with 2.5 mm balloon, which was a soft lesion. It yielded very easily. Placed a 3.5 into 38 mm drug-eluting stent from left main ostium into the middle LAD and deployed at about 12 atmospheres. Then after that, pot was performed with a 4.5 mm balloon. Then circumflex was re-accessed, kissing balloon, and then repot. And angiographically, it appeared to be a satisfactory result. But when we performed the intravascular ultrasound, the distal stent MSA was about 8.4, proximal was 6.7. In absolute terms, any MSA of more than 5.5 millimeters squared by intravascular imaging is supposed to be satisfactory. But when we estimate the vessel area at that site, the vessel diameter was 4.6, which was contrary to what was our baseline assessment, which often happens in acute coronary syndromes, because once the stenosis is relieved and we give intracoronary vasodilators and stent is placed, the vessel grows in size. So the stent size by the vessel area at that MSA site was not satisfactory. And the ostium of the LAD had a 7.43, distal left main and proximal left main had the minimal stent area was not according to the recommended standards. So we post-dilated the proximal LAD with a 4 mm balloon, kissing balloon with a 4 and 3 mm balloon, and then pot with a 5 mm balloon at the left main. Then achieved a minimal stent area of 8.7 in mid and 9.9 in proximal. Ostium was 9.7, and we could achieve a minimal stent area of more than 10 mm squared at all sites in the left main. And there was no edge dissection or malapposition or under expansion. It was stented from the ostium of the left main all the way into the middle LAD. So that's ostium. So that's an angiographic result. There was TIMI3 flow in both the LAD and circumflex. So among the stent expansion indices, there are different criteria by which we go by what is the optimal stent expansion. From the recent meta-analysis of studies, just found that in a subgroup of studies from ADAPT found that among the stent expansion indices, the minimal stent area by vessel size at the MSA site, if it is more than 40%, then that discriminates patients who have lower MACE when compared to those who develop MACE. And we know that very few lesions will have lesions limited to the ostium of the LAD or circumflex. Majority of the cases, there will be lesions which will be extending proximally into the left main. So, and also this group also showed that the positive predictive value of angiogram in detecting a lesion in the distal left main is rather low. So in patients who have lesions which are limited, have angiographic lesions at the ostium of the LAD or circumference, it's better to perform an intravascular imaging to detect any plaque which is extending to the left main. Most often it will be there. And these are the predefined criteria for IFS optimization: left main lesions, ostium on the midshaft on your left and distal left main on right. We didn't have a reference segment to compare, but we went by the absolute value. In Excel trials have shown that if you have a minimal stent area of more than 11 millimeters squared, that discriminated patients who had a maze-free interval versus those who had in events. And in Noble, it was more than 13.5. So in our case, we aimed for a minimal stent area of more than 10 mm squared and performed a pot with a 5 mm balloon and achieved that stent area. Thank you for the patient hearing.